warm welcome to you all on behalf of Nepali Society of Critical Care Medicine and Nepal Society of Nephrology. I am Dr. Hemraj Paneru, an intensivist at New Teaching Hospital, and I am General Secretary of Nepali Society of Critical Care Medicine. So that the presentation can be made interactive. All everywhere. So without much delay and making this a very formal program, I would like to start. First of all, I would like to welcome the speakers. We have a distinguished critical care specialist who is heading critical care services at Max Hospital, New Delhi, Dr. Ritesh Agarwal, for being here all the way from Delhi for his talk on hemoperfusion. And the next speaker on second half will be Dr. Naveen Basnet, who is a nephrologist at Sumeru Hospital. So he is going to share his experiences on hemoperfusion. So to begin with, I would like to request respected Professor Dr. Dibya Singh Saha, Vice President of Nepal Society of Nephrology, to extend warm welcome to our distinguished speakers with handing over bouquet and khada. So I would like to request Professor Dibya ma'am to come in the front, and I would like to request Dr. Ritesh and Dr. Naveen to come over in the front to receive the welcome bouquet. Who is an intensivist and critical care lead at Max Hospital, New Delhi. He has a long experience of 30 years in critical care and has several publications in international journals. And he has good experience with this hemoperfusion therapy. And he will be sharing the role of hemoperfusion therapy in sepsis and COVID-19. So I would like to invite Dr. Ritesh over here to begin his presentation.
Good evening, everybody, and warm greetings from India. I am Dr. Ritesh from Max Hospital, Saket, New Delhi. And thank you to the Critical Care Society and the Nephrology Society of Nepal for inviting me over here, and to JAFRON and SPP for organizing this session. So, before we start, I would urge all of you to download this app. It's available in Apple as well as Android. All of you have downloaded this. So this is going to be an interaction tool for all of us. There would be some simple questions to which you will be anonymously answering. Okay? There would be live display of those results. None of this data is being captured. It's absolutely anonymous. So that this is basically a learning tool. So I hope everybody, can we have these lights switched off, please? Okay. So if all of you have downloaded this, let's try that whether it is working fine with all of you with a test question. So I'm putting a test question to all of you. So the test question is that just check whether this question is appearing on your screen, and just try to reply to that. So that also tells me that most of you belong to me anyway. Okay. So so basically, when it comes to cytokine filtration, we at Max Healthcare, although we were sporadically using cytokine filtration once in a while in our ICU, but when it came to second wave, our usage of cytokine filtration tremendously increased. So we used it in many patients, and to tell you frankly, we did a few mistakes also in using that. When to start, how much, when to stop. So we did those things. But this wave gave us an opportunity to understand, learn, and experience how the cytokine filtration work and when it doesn't work. So that's how we started using it. And then once this COVID wave was over, we started extrapolating this to sepsis also. Because previously also we had used, but it was like once in 1 month. So that was not giving us any concrete direction. So then we applied it to sepsis, and again we had some hiccups because cytokine filtration behaved differently this time in sepsis and compared to COVID. So the purpose of this talk is not to bombard you with scientific literature or studies to show that yes it works or yes it doesn't work or some meta-analysis. That's not the purpose. The purpose is also not to show how big or how complicated cases we have done in Max. That's not the purpose. The purpose is to tell you the basics of cytokine filtration. What is the scientific rationale why we should do it and when we should do it. So if we equip you with the knowledge of cytokine filtration, then you are the best judge to choose filtration in your patients. Okay? So I would discuss some basic concepts related to dialysis, related to filtration, and related to difference between the two things. Then, which patients will benefit from cytokine removal? That is one thing which is there in everybody's mind. And the most important question: when should you start cytokine filtration? What is the point? Is IL-6 the marker? So what is the basic thing? Can we have some specific biomarker to say that yes, now cytokine filtration should be done? And then, once we have started cytokine filtration, what should be the duration of a session? Okay, and more importantly, how many sessions should be given to a patient? Is there anything that can guide us that okay, 2 or 3 or 4 sessions are over? So, like in initiation, is there a biomarker, the same or different, which can tell us that the cytokine filtration should now be stopped in this patient? And finally, what are any potential complications of cytokine filtration? And then, if time permits, I will share briefly some of the data of cytokine filtration in COVID as well as in sepsis. So, just to start with a thought-provoking question, I want to ask all of you, what do you think? Can we remove these sepsis cytokines like interleukin-6 and TNF-alpha or endotoxins with a routine dialysis? So can your nephrologist straight away do a dialysis and then you can feel that yes, some amount of these cytokines are also removed? So your choices are that no, that's a different thing. Cytokines cannot be removed at all. Or second one, yes, by using CRRT. So not the routine dialysis. Third one is that yes, the routine dialysis can remove them. And fourth one is that CRRT can remove it, but we need to do some modifications in that CRRT. So the basic concept is, where does dialysis stand when it comes to cytokine filtration? Can I have some water? So I'm slowly getting these responses. I would request all of you, because let us spend more time in discussion and interaction. Please be open. You can just raise your hand, I will stop, and we can discuss any point related to this. I am sure we are at least 50 here and there are only 14 responses. So many of you feel that we can modify CRRT in some way and then we can remove the cytokines from sepsis patients. Okay. So that brings us to the discussion of this first and basic question. So let us review what basically dialysis is. In dialysis, we are basically removing solutes from patient's blood, and there are 2 ways we can do it. The first is diffusion and second is convection. So what is diffusion? In diffusion, the dialysis filter or the thing that provides a membrane, on one side of that is patient's blood, on the second side is a dialysate fluid, and then there is a movement of solute particles from patient's blood to the dialysate fluid. So those toxins or solutes are removed, down a concentration gradient. Say for example, the urea and creatinine, they are more on patient's blood and they are not there in the dialysate fluid, so they move across the concentration gradient. This is what is diffusion. The other strategy which is used in dialysis is convection. In case of convection, what we basically do is that there is a membrane again. On one side is the patient's blood, on the other side is the dialysate fluid, but we apply a pressure this time. When we apply pressure on one side, that pressure leads to movement of solvent, movement of fluid across the membrane, and along with that solvent or fluid, there is movement of particles secondarily. That is called as convection or ultrafiltration. Okay? If we use purely diffusion as a method of dialysis, this is called as hemodialysis. And if we use purely convection as a method, this is called as hemofiltration. And most of the time we are using combined, that is called as hemodiafiltration. So that is the basic terminology which we use. So what you need to understand is that hemodialysis will remove only small particles. Larger particles will not be removed by hemodialysis. So hemodialysis removes particles of the size 5 to 20 kilodaltons, and the particles which come in this range include urea, creatinine, and your electrolytes like potassium, calcium, for which dialysis is done. Okay? As the solute size will increase, the diffusibility or the movement through that membrane is going to reduce. You can intuitively understand that the diffusion will reduce. Now the thing is that cytokines, the important cytokines, have a size range of 10 to 60 kilodalton. So you can understand that these are larger size solute particles, so they will not be able to be removed by diffusion. Okay? So can anybody think, if I have to use diffusion for these cytokine removal, what I will have to do? So the limiting factor is the pore size across which the solute is going to move. So I will have to increase the pore size, and I will come to that, what is the problem with that. So dialysis, we are having an issue that dialysis cannot remove cytokines. Coming to convection. So what occurs in convection is, because we apply a pressure gradient and there is a solvent drag into that, so if we somehow try to increase that pressure and ultrafiltration, there are chances, because solute particle is not a limiting factor in convection. So then there are chances that these middle-sized molecules like cytokines can be removed. So what we learn is that convection is probably an area where we can work upon to remove cytokines from the blood of sepsis patients. So let us understand what people have tried. People have tried to modify dialysis and they have tried to modify convection. So what they have done is, they have done two things. First is the high volume hemofiltration. High volume hemofiltration is a modification of convection where they have applied large pressure to remove large amount of ultrafiltrates to the tune of 35 to 40 ml per kg per hour. This is a large ultrafiltration. And when that much amount of solvent drag occurs, then the larger molecules like cytokines are removed from the patient's blood. So they have tried modifying the convection. The other team, the diffusion team, also tried. They tried to increase the size of the membrane pore, so that when the smaller molecules like urea, creatinine move, there is also chance for the larger molecules like cytokine to diffuse. But there was a flip side. The flip side was that when they were removing the larger molecules, there was a loss of albumin, vitamins, minerals, because their size range is also close to the cytokine size range. So that became an issue. But anyway, even if we leave these two things, the studies done on these two modifications of dialysis for cytokine removal, they didn't show any significant good results, either in terms of cytokine level reduction, nor in terms of mortality or vasopressor or morbidity and those things. So dialysis and convection have been tried for cytokine removal, but they have not been found to be successful. So that is the first concept which we should understand. And this is what I was trying to tell about the size thing. So when it comes to dialysis, we are targeting this range. Look at the size of urea creatinine. It is less than 1 kilodalton. That small. And herein lies potassium and calcium and those things. When it comes to cytokines, just look. This is IL-1, roughly here. This is IL-6, IL-8, IL-10, TNF alpha. So that is the range of these ones. So we need to precisely somehow hit this size range. We do not want this, and we don't want to go beyond that also, because we are going to lose albumin. So that is an issue. So we have to work on this particular range only. And therefore, the third method, the third technique of dialysis came, and the third, by the way, if anybody is interested, this is an old but a very good review article which has explained all this evolution, how they have tried continuous hemofiltration for cytokine and what they have found, and I have written the same thing. They found that there was a significant loss of these molecules, and therefore it is not a useful thing for cytokines. So therefore comes the third method of solute removal, and which is called as the hemoperfusion or adsorption technology. Okay. So what is this technology? So just try to imagine that there is water lying over there, and you put a piece of sponge on that. The sponge will just take away all the water inside it. That means the water molecules will cling to, they will get adsorbed to the sponge. So that is called as adsorption. So it is a blood purification therapy which is basically based on adsorption technology, and using this we are removing the cytokines. So cytokine is one thing. You can also remove drugs, you can remove poisons, you can remove bilirubin, you can remove many things. So with specific filters. So now the thing is, try to understand. In case of routine dialysis, there is always a membrane between the patient's blood and dialysate fluid. So the blood never comes in contact with any significant foreign thing. In case of adsorption, you need to run this blood right across the filter. So that means there is a significant exposure of patient's blood to foreign things. And since that thing happens, there are chances of complement-mediated reactions. Okay? So this is the point which you should remember, because we will understand the practical implications of this when we use cytokine filtration. So whenever there is blood in contact with this thing, the incompatibility reactions like fever, chills, and those things, some hemodynamic variations that can happen. This is the hemoperfusion cartridge which we use. This contains polymer beads, multiple small beads, which make a basically crisscross network through which the blood flows. And the studies show that the cytokine filter will remove 90 to 90% of cytokines which are present in plasma at that point of time. Okay. And now the other thing is, unlike the diffusion or convection, where you can extend the dialysis, say from 4 hours to 6 hours to 8 hours, because there is just a membrane, adsorption cannot be extended, because here the same particular thing is absorbing the chemical, so it will get saturated. So there is no point in extending the cytokine filter for beyond 3 to 4 hours. It just gets clogged with this thing, and in other words, if the whole sponge is filled with water, so then it will not be able to absorb any more water. So there is a limitation to which we can use. This is the diagram where I have tried to show. This is the filter. You see the cross section of filter. This is the sponge-like material. You enlarge it. These are the crisscross polymers through which the blood flows and get absorbed. You further microscopy it, and this is the thing. And these are the polymer, and through which the blood is flowing and the toxins are getting absorbed. The toxins get absorbed. The most important thing is size. Okay, I'll show you how that happens. The second is the hydrophobicity of the toxin, and the third one is the electrostatic charge interaction. So the filter tries to selectively attack one particular group of molecules based on these three properties. So this is just a diagrammatic representation of what is happening in a cytokine filtration. This is the filter. Now this is the resin, which we are using. This is the cytokine present filter. This is the blood, and then we have got these smaller molecules in yellow, like urea creatinine. Then we have got the middle molecules here in brown and blue. These are our cytokines, and then we have the larger one, the RBCs. So you can see the smaller one will just slip through. They will not be, because their size is too small. So they will not be absorbed by this thing. So this is not going to take care of the urea creatinine. The middle molecules will be attached over here. They will get absorbed. The RBC, because of its electrostatic interactions and size, that will escape. So RBCs will also not attach. So that's how a cytokine filter works in principle. So now comes the question that if you remove cytokines in sepsis, why is it proven, or is there something to say that removal of cytokine will improve the patient? So, and if that is so, why should patient improve if you remove cytokines from patient's blood? So there are two theories to explain that. Both of them are very interesting theories. So let us try to understand that. So in the dotted line, what I have shown is, in the dotted line, this particular one is a pro-inflammatory phase of sepsis. This is the anti-inflammatory phase of sepsis, which happens routinely. And in response to these cytokine inflammatory and anti-inflammatory stage, there is an organ dysfunction, which is shown in this dotted line. Okay? Now, first thing to understand is that previously we used to say that the anti-inflammatory mediators are always our friends. They do not cause any injury. But the current understanding is that anti-inflammatory mediators, when they shoot above to a very high level, they are also responsible for causing organ injury or tissue injury. So what cytokine filtration is doing is that cytokine filtration is removing a part of these pro-inflammatory and anti-inflammatory cytokines, thereby reducing the degree of organ dysfunction. Okay? So what I am trying to say is that there was a criticism that cytokine filtration is going to remove anti-inflammatory mediators also. So how is it going to be beneficial to my patient? It is also removing my friendly anti-inflammatory mediators. So that theory is also laid to rest, because the anti-inflammatory mediators also cause two things: immune paralysis, that means increased risk of secondary infection in ICU, and second is organ injury. So if excessive amount of anti-inflammatory mediators are also removed, that is also a beneficial effect. That is what I am trying to say. So this is first theory, how cytokine filtration helps. The second theory is what is called as the cytokinetic theory. Cytokinetic theory says that when you remove the cytokines from plasma, then there is a concentration gradient which is created between the level in the tissues and level in the plasma. So the plasma cytokine concentration will fall, tissue concentration of cytokine will stay high. This, because the cytokine concentration in tissue is high, this will attract WBCs more and more into the tissues. This will lead to two good things. Number one, it will lead to better clearing of infection from the infection site, and second, because RBCs are taken off from the plasma to the tissue, there would be less damage to the healthy tissues. So if you have not understood this one, just see this figure. This is the tissue, this is the plasma. The plus are the cytokines. So initially there were good amount of cytokines here, good amount of cytokines here. The green boxes are bacteria. So bacteria, obviously, they were more in this pneumonia lung. They were less over here. And then the third thing, the oval one, are the leukocytes. So leukocytes were less here, almost equally distributed in plasma and lung. If I remove these plus from the plasma, what will happen is that these plus or cytokine level will concentration will be much more in lungs or any tissue. This will attract all WBCs over here, and thereby, number one, this lung is going to improve better, And number two, because we have less WBCs over here and WBCs related various chemokines are less over there, so the healthy tissues would be safe. So these are two theories which explain how cytokine filtration works. So we have now understood the basics of cytokine filtration. Let us now take one case scenario and then we go through this that will try to help us learn how to use cytokine filtration at the bedside. Okay. So a routine patient, nothing fancy, 50-year-old male diabetic, COPD, pneumonia, admitted ICU, and leukocytosis 21,000, creatinine slightly high 1.2, type 2 respiratory failure, lactate of 2.8, blood pressure borderline, not very low, but 98/62. A quick echo was done, echo was fine, procalcitonin was done, procalcitonin was 2.2. So I think this is a routine case, all of you must have seen many times. So an initial sepsis management, NIV, antibiotics, fluids, bronchodilators, steroids. Those things were started for a COPD pneumonia sepsis management. So you have seen this patient. I want to ask all of you, and so what do you think? Okay, so let's proceed to day 2. On day 2, this patient worsens and he goes on ventilator. He is on 40% FiO2. His TLC is still high, slightly more. Creatinine is 1.4. His lactates are okay, 2.0. But his BP fell little further more and he was started on low dose of noradrenaline. He is maintaining his urine output so far, 40-50 ml per hour. Procalcitonin is 2.6 and interleukin 6 is 260. This is the situation on day 2 of worsening pneumonia COPD patient. Now, you tell me from your intuition, would you like to do cytokine filtration in this patient? And don't get carried away that this lecture is about cytokine filtration, so you are anyway supposed to. That's not the issue. Just think for yourself, you are in ICU. Would you, in your patient, like to do cytokine filtration for this patient? Good, 23 responses. Okay, so clear cut that you would not like to do cytokine filtration in this thing. Let's proceed. On day 3, this patient worsens slightly more. He is on 50% FiO2 now. Although counts are better, creatinine is okay, lactates are okay. NORAD has now gone on higher dose, and there is slight drop in urine output, and creatinine also 1.9. Okay. So his procalcitonin is 4.6, but his IL-6, somebody sent it again, okay, and his IL-6 has improved. Last time I think it was 400 something, and it has improved to 190, but procal has gone up to 4.6. So this is the situation, and my question is, now at this worsening stage, would you like to go in for a cytokine filtration? Okay, so 60% of you would not like to do it, and 40% would like to do filtration at this point of time. Let's move on. On day 4, this patient worsens further. Now he is on 80% of FiO2 and his TLC is high, his creatinine has jumped now from 1.9 to 3.7, his lactate's gone up, he is in metabolic acidosis, he is almost anuric now, and he is now on noradrenaline high dose and a second vasopressin infusion has been added. Okay, and in view of all this metabolic acidosis and things, CRRT has been started. Okay, so now my question is, okay, so somebody sent these levels again, okay, and the procalcitonin comes 6.6 and IL-6 shoots to 800. Okay, so now would you like to go in for cytokine filtration? So this is a good. So I'm not just trying to make it trying to look things this thing. This is how it happens in our ICU, and at these stages only we have to take decisions that when should you finally talk to the family. This is the first therapy. You have to. The family is going to spend around 40,000 for one filtration. Okay, but if it is giving benefit, you hold the key when to approach. Okay, for that you need to be equipped with the rational and knowledge. Okay, so 81% of you would like to do cytokine filtration at this point of time. Fine. So you have answered these three scenarios. Now tell me one thing. When you were choosing these therapies in these three scenarios which we discussed right now, which was the factor which influenced you? Was it the IL-6 going later high, initial high, whether it was, TNF alpha I didn't get, whether it was the procalcitonin which was influencing your decision, whether it was the lactate going up which was influencing your decision, or vasopressors which was influencing your decision, or was it that since CRRT machine is already in place, I might as well put a second filter that is easy. So, what do you think has the potential to give you answer about starting the cytokine filtration? Okay, so almost a divided response. Wherein you are saying that high vasopressors and IL-6 alpha you would like to do, and very few would like to go in for procalcitonin and lactate. So, okay, so now you know where is the confusion, and now let us understand that when should we, what is the practicality, how do we go about it. If you look at the pathophysiology of sepsis, this is a very, very complex thing, and even what this has shown is still a simplified version. The things are still more complex. Many pathways leading to another pathways, each pathway reinforcing each other. So this is a complex thing. Let me try to simplify the pathophysiology of sepsis in few lines. It's simplification, but that will help us in the cytokine filtration aspect. What basically happens is that there are bacteria, pathogens. These pathogens, they release endotoxins or exotoxins. Okay? They release these toxins in the blood. Now, there are host immune cells. So, by the way, the latest fancy terms for these toxins is PAMs, pathogen-associated molecular proteins. Now, these PAMs are recognized by the host cells, by some receptors. They are called as now the PRR receptors. Now, these host cells release some inflammatory mediators. So, the first one to be released are TNF alpha and interleukin 1. Within an hour of all that, TNF alpha levels goes high. This TNF alpha then activates neutrophils, monocytes and macrophages, and this leads to two things: release of pro-inflammatory mediators and release of anti-inflammatory mediators. So these are few prominent pro and few prominent anti-inflammatory mediators. And then, as I said, these two will create havoc in tissues and will lead to tissue injury. And when they do this tissue injury on liver, on other tissues, they release various things, procalcitonin and CRP and lactate. So what I am trying to tell you is that the potential lies at multiple levels. The potential lies if I can measure endotoxin, if I can measure TNF, I can measure IL-1, I can measure this one, I can measure this one, I can measure this one. So these are all the things which probably can guide us when to start cytokine filtration in sepsis, but very confusing. Okay. Again, if somebody is interested in reading this, almost it is the same thing which I said, but that was a summary of this. That what are the potential therapeutic targets in sepsis? Just spend 1 minute on this one. What this particular review is saying, same thing in different words is, there is an inflammatory response in sepsis and there is an anti-inflammatory response in sepsis. You can see the inflammatory response typically overshoots the anti-inflammatory response in this phase, and then in the later phase it is the anti-inflammatory response. So what they are saying is that please target at this level. There is no point of doing cytokine filtration here. There is no point of doing cytokine filtration here. This is the game is over. This is, I think you would be doing it in too prematurely and no benefits for that cost. This is the area where you need to hit. So everybody says this, but how do we define this area? That is the clinical dilemma bedside. Let us look at the first target, which is the TNF alpha, because we I think here also you are able to measure IL-6 and TNF alpha, these two things. So should we do that or should we not in sepsis? We saw that it is a central mediator. It was released very early in the sepsis, and they have tried injecting TNF alpha in animal model, and they say that TNF alpha is such a central mediator that you give it to the animal and it shows all features of a severe sepsis. So that means it's a complete molecule, and I wish we could use it as a marker of cytokine initiation. But the problem is that TNF alpha levels, they don't correlate with the level of sepsis or septic shock. So in severe sepsis, they have seen TNF alpha are very low, and vice versa. In low grade sepsis, TNF alpha levels were high. Okay, so probably this has lot to do with the surge in TNF alpha which comes initially, but later on the surge quickly dies off after stimulating and the other cytokines. So the nutshell thing is that TNF alpha cannot be used as a measurement thing for starting of the cytokine filtration. Okay, so that is about the TNF alpha. Sorry. Coming to the interleukin 6. Okay, so favorite of all of us is the IL-6. Now this became hugely popular in COVID-19. There are multiple studies and meta-analysis which showed that IL-6 definitely correlates with cytokine storm, it correlates with mortality, it correlates with the degree of COVID severity, and it's a good marker to suggest cytokine filtration in COVID. And we all have used it. But there is a problem. IL-6 in sepsis is an entirely different ballgame compared to IL-6 in case of COVID. What happens? In sepsis, the IL-6 high level can lead to downregulation of IL-6 receptor on the cells and tissues, and vice versa. So the biological activity will be dependent on the tissue, the receptor. It is not dependent on how high my IL-6 levels are. So if the IL-6 levels go very high, the tissues will quickly downregulate their receptors, so IL-6 is not working. So what I am trying to say is that the biological activity or sepsis or inflammation doesn't correlate with IL-6 levels in sepsis. Okay, that means that IL-6 levels may not be guiding us for initiation of cytokine absorption. Okay, so at the best, interleukin 6 levels can have, so if the levels are very high, they can have a corroborative value, but they cannot be used as an absolute cutoff. If the levels are more than 1000, I think now I should think of, or levels are more than 500, I should think of. Like in COVID, one of the level which we even in our ICU we used was a cutoff of 1000. So if the IL-6 was doubling and was crossing 1000, we were discussing with families about the cytokine filtration. So what I am saying is this doesn't hold true in sepsis. So that is the issue with IL-6. Coming to the procalcitonin and lactate, you all must have understood by now that lactate and procalcitonin are the end results of injury which is caused by various cytokines. That means if these are elevated, then the cytokines are hard enough to hit the tissues and cause damage. That is why procalcitonin and lactate are considered, these are considered as the markers for initiation of cytokine filtration and not the interleukin 6 and TNF alpha. So if your lactates are jumping up, if those things are happening, if that clinical headache is happening, that will guide you about cytokine filtration. Don't run and chase, because IL-6 is a costly test. I am sure here also it must be a costly test. So rather than chasing interleukin 6, we need to look at other things. If you are doing these scores in your ICU, then this is almost the same thing as above. So you can do procal lactate as a tissue injury marker, or you can do these scores and see how much is the tissue injury. So these are the things which we should be used. So, by the way, so if we, whatever I am talking, what is the clinical evidence in studies related to this? So I won't go in detail of any of these. I will just say these are 3 good articles in this particular area about when to start hemoperfusion in sepsis. The first one in critical care, 2016, I think, and they said that we feel that high vasopressor and high lactate are the starting point of cytokine filtration. This journal in critical care, this team felt, this was an RCT, and they felt that the moment multi-organ failure sets in, that's the point. The early stage of multi-organ failure is the point where you should do cytokine filtration. This is a very good review article. All of us should read it if you are interested in cytokine removal in septic shock. And they say in their review that the high vasopressor requirement and illness severity score, they are more important. So you can see it's not about IL-6 measurement, it's not about TNF measurements. So it's about the clinical picture. So if I sum all this up, because I wanted to spend a little more time, because to tell you frankly, we have evolved most in this area, when to start. So that's why I wanted to spend a little more time. So the summary of initiation is, look at the clinical picture of inflammation. If the inflammation is going really high speed, that means your vasopressors are going escalating straight away high, despite your fluid resuscitation and first 24, 48, 72 hours of antibiotic, that's the time you should think of. Don't think at the beginning. So that time everybody is in shock. You resuscitate that patient for 24 to 48 hours, and if that, even then the vasopressors shoot high, that is one big clue that filtration should be thought. A very important clue is that there is a new organ dysfunction. So patients with sepsis who comes with AKI, that is a different thing. That we are not bothered. Most of them comes with AKI. But if the AKI jumps after 2-3 days, suddenly shoots up, if there is a liver dysfunction coagulopathy, if the patient is becoming obtunded, that is the time you should think that the organs are crying, we need to give some additional support. Once this organ killing starts, that time please be very quick. Within next 12-18 hours, make sure that filtration is started if you want to go for it. Because if you do it late, then the game is lost. Among the various injuries, AKI is one which is very, very sensitive. Studies have shown that we have also experienced in our ICU. The moment there is a rapidly deteriorating AKI, we are quick in thinking whether we should go or not go. We have to decide for that. And yes, please don't wait for hemodialysis or CRRT to start with. So don't have that tendency. If you have to do cytokine filtration, maybe you can save the patient from CRRT or hemodialysis. Just put in a catheter and your nephrology team is ready to do pure cytokine filtration also. So that should be the strategy. Another one I said, if your lactates and procalcitoninas are rising on day 3, day 4, despite your adequate antibiotic and therapies, that is the time when you should think of this thing. Serial levels are helpful in this situation. And we have found, because we were closely watching, whether it is the lactate which is better decision maker or procal. Somehow in our limited experience, we have seen that procal seems to guide more. So if my patient's procal goes up from say 2 to 7 or 8, and simultaneously there is either a vasopressor spike or there is an organ injury, that is how I would decide about that. So the bottom line is that a rapid worsening patient, despite. So you have to define rapid worsening. You can choose if any of these two out of these three are present. I think you should start thinking on cytokine filtration. So we come back to our case. So I asked you three scenarios. So probably I feel that the middle scenario, when the vasopressors were getting high, when the urine output was dropping to 20-30, when the creatinine was jumping to 1.9, probably that's the better positioning of the cytokine filtration. So let's presume that we did that for cytokine filtration. By the time family consented, everything happened, the metabolic acidosis worsened, and now your nephrology team was involved for that, and they said that now is the time where we should anyway do dialysis because his metabolic acidosis and hyperkalemia and everything is there. So my question for you is this, that what would you do? You would like to now proceed with hemodialysis without filter, without the cytokine filter. You would proceed with cytokine filter, and you would wait for routine hemodialysis and understanding that it might remove some of the uremic toxins also. And the third thing is that you would like to do two things together, hemodialysis and hemofiltration. So the moment I start showing responses, then the bias comes. Although I think there is no option of reverting your answer in this, or you can change your answer. No choice. Okay. So the thing is, dialysis is a different thing, hemofiltration is a different thing. The correct answer is that you would like to go in for both the filters. The two filters are different, two are separate entity. Both can be placed in a series like in the lower diagram. So here I have placed, this is the cytokine filtration. The flow goes from below in this to up, and then there is a dialysis filter, and that's how it's going on. And the upper one is that it is a standalone procedure where you can do that. So the better option is that you go in for both things together. Okay. So fine. So we decided that we will go in for a dialysis as well as filtration, and the procedure was started on the patient. 5 minutes into the session, and this really gave us very bad time in COVID, the patient developed hemodynamic instability. 0.08 mics was the NORAD when we started, and 5 minutes later this patient goes 0.10. So I do not know, so we had a very bad time when these things happened. 0.5 was the FiO2 and 0.60. So I used to get my call from my consultant, this thing, कि सर ये तो cytokine filtration से पहले ही खराब हो गई, मतलब start करते और खराब हो गए. And that is the situation that you start filtration and then that goes away. So the question is that what would you like to do? You would like to discontinue filtration, but so you would like to discontinue this particular filter but like to go on for dialysis? You want to go for, you want to stop both for a few minutes and then restart again, or you just want to reduce the flow rates for some time? So when you start using it, this normally the literature on this particular issue is less, but I do not know whether it is Indian population related or what, because as we are using more and more volume, and this is happening, this we are still observing in 15 to 20% of the patients. You start them on the device and they start getting these jitters. So you say that the responses are that, okay, great. So exactly this is how it should be tackled. So some patients may show this response, and our experience has shown that usually we have seen that in younger patients, and we saw this much more when the cytokines level were huge, like in cytokine storm, and this happens in our case, and few case reports also. First session, and somehow our incidence was much more with cytosorb as a filter when we used as compared to HA330. I think one patient with HA330 developed it out of so many we used, and 4 in the cytosorb thing. And so you basically just stop it for some time, reduce the flow, restart, and most of the times we have seen that it gets settled. In fact, initially we used to get very worried and we used to start giving hydrocortisone and Avil and those things. We have stopped doing those things also. So the likely reason is that first time he is exposed to this, so it can be a complement mediated reaction. The other reason which we read in few of the article is that when the huge amount of cytokines are taken off in a cytokine storm situation, then there is an endogenous catecholamine response. So NORAD, ADR, endogenous, they play some reaction. That's why the patient goes into hemodynamic instability. So this is one practical thing which comes when you start this cytokine filtration. And briefly, only 2 studies. What is the evidence says that when you use hemofiltration in sepsis, what happens? This is an RCT of 44 sepsis septic shock patients where they used cytokine filtration 3 days, and they found that there was a reduction in mortality, length of stay, and vasopressor requirement. So this is one. Since it's an RCT, I wanted to show this to you because many of the studies are either biased or there are a lot of confounders. Because in COVID you get so many things in one arm, so many things in the other arm. So you really don't know what was. And the second study is this one from China, and where they used 118, they took 118 septic patients and divided it in 3 groups. Conventional treatment, only CRRT with filtration. So the V group is the cytokine filtration plus dialysis. So if CRRT plus filtration was done in that particular group, they found that the SOFA score improvement was good and the oxygenation. So I deliberately didn't include studies which looked at mortality because I feel that mortality is not an indicator to look at things in ICU. Mortality is affected by so many things. So probably if you have to see the effect of cytokine filtration, let's look at how much is the BP improvement, how is the organ injury improvement, oxygenation improvement. Those are the indicators and not the mortality. By the way, in this study there was mortality benefit also. So there was a benefit in survival. So the almost last scenario, that this patient underwent finally first session of cytokine filtration with dialysis, and there was an improvement in hemodynamics and ventilator requirement over next few hours. And then there was a significant improvement in procalcitonin level. But since we were so much used to measuring interleukin 6 level almost 2 times in a day in every patient, so in sepsis the habit continued, and we found that post filtration this patient had an increase in IL-6 level. And our clinical dilemma came because we used to counsel the families that see the patient is bad, this your interleukin 6 levels are this, so we should do cytokine filtration. And next day invariably they will say, sir, IL-6 batao. So that used to become a very strange situation that how do we now explain IL-6 to बढ़ गए. So when you start doing it, you will face it. I am telling you, to the extent that we are seeing this now in almost 40% of patients, the IL-6 level go up. And I just want to also you to focus that this is the level of lactate and this is the level of procal. Just look at these levels because we have some important implications. So we have an improvement in lactate, we have improvement in procal, we have improvement in hemodynamics and oxygenation in this patient. However, our interleukin 6 has jumped. So now the next clinical decision which I have to make is whether I plan further sessions in this patient or not. So no more sessions. I would like to give another session because IL-6 is high. I would like to give 2 to 3 more sessions because we should do that. And otherwise, I think we should continue for at least 5 sessions in any such septic shock patient. So the second very important clinical dilemma which we faced was that how many cytokine filtration sessions should be offered to a patient. Okay. So, and then these levels of inflammatory this thing. So when you made that decision that there was an improving lactate, improving procal, rising IL-6 and improving hemodynamics. So again, what made you decide that you would not like to go in or you would like to go for next session? So you feel that the procalcitonin fall is the most important reason for deciding that now we should not probably on procal you would have decided that we will not do that. So this is very, very important, that how do you interpret your labs once you are on filtration. This is important. Look at this. The problem with procalcitonin is that, look at the size of procalcitonin. Procalcitonin size is 13 kilodalton. Isn't it coming between 10 and 60? So the flip side of procal is that procal is a very good thing to help you decide the starting of cytokine filtration, but there are chances that it gets absorbed by the filter. So please don't use, and we have observed that I was telling you that we felt procal was better than lactate in starting, but procal is not a good thing for stopping this, because procal low can be just a result of heme absorption for that. Coming to IL-6. The levels of IL-6, because you need to know this to explain the family and yourself what is happening. IL-6 can paradoxically stay same or may even paradoxically rise after cytokine filtration. And the reason for this is, number one, so the reason for this is that your pathological process is continuing to generate the interleukin 6. And the interleukin 6 levels, when your pathology goes up, actually rise exponentially. One. Second, IL-6 is a cytokine. When the plasma levels go down, then besides the new IL-6 formation, there is a back IL-6 levels from tissues to plasma. So that's why, so this doesn't happen in every patient, but at least in 25-30% of the patient, you will see IL-6 is either not settling or it is paradoxically rising. Okay? This anyway doesn't guide us anywhere. It doesn't help us in telling that we should stop or not. So that in fact, there is no point of chasing the patient with IL-6 after you do cytokine filtration. Lactate is very important. If your tissues are getting better, if your tissues injury is reducing, that is a good follow-up marker. And the second good follow-up marker is reduction in noradrenaline. So if your patient's vasopressors are reducing and his lactate is improving, oxygenation is improving, again, the clinical markers are much better than the biochemical markers. Same thing was discussed here, the IL-6 controversy, which same thing they said that although the patients improved hemodynamically, but the IL-6 levels, they didn't go. So the same thing was discussed in this particular RCT. Okay, and this is some literature. So because of short of time, basically same thing they are mentioning. So our understanding with cytokine filtration is that in those patients, whether it was COVID and sepsis, where we do at least 3 sessions to remove consecutively, then the levels of cytokines are reduced enough that the patient gets improved. And so our strategy now is that we continue to do that. Even if the patient improves, we give a minimum of 2 sessions, optimal 3 sessions. I again repeat, cost comes as a factor in our patients also, and so therefore we need to balance those things, but we try to explain it to the families that a 3 session is an optimal dose of cytokine filtration. And now IL-6 is not the thing where we will be able, which we will decide, and we did our each session for 3 to 4 hours. We did it once in a day, and we did it back to back for 3 days. So now when we were counseling our patients, and now what we do presently, we straight away tell this is a therapy of 3 filters over 3 days, period. If they are okay with it, we will proceed with it. Last scenario is this happens. So this particular patient developed thrombocytopenia. His platelets were 1,50,000 and now the platelets dropped to 80,000. So you have to think a sepsis patient, thrombocytopenia on filtration. Oh, so I think I missed putting a question over here. So continue with second session, transfuse platelets and proceed, or wait for platelets to recover and then proceed with next session. So how many would you like to go in for one? Okay, continue. How many would like to go in for second? How many for third? I think you are. So it's an uncommon complication, but that happens. Again, it's a complementary related reaction to the foreign substance. Please remember, like in any other thrombosis. So this is not DIC. So we have gone and done workup in our patients to look at fibrinogen, D-dimer and those things. This is not D-dimer, this is not this thing. This is just a complement-mediated injury and leads to peripheral platelet destruction. They don't go below 50,000. So we continue. If they come below 50,000, definitely you would like to hold and you would like to see, but that doesn't usually happen. So I think our experience and our learnings I have shown, because, sir, should I skip this one or should I briefly show? Okay, so very briefly, our data. Total patients we have used is 60. So the data we are able to compile is in last quarter to 2 years. In fact, COVID data also we took some retrospectively. 68 patients, most of the experience is with HA330, and now we are actually moving away from cytosol to HA330 because the principal reason is cost and second is the reaction. So we are finding less reaction in this one, and the cost is around 50 or 40 to 50% of cytosol. So that's what we are doing. And we used it, COVID we used it in 50 patients, sepsis we used it in 15 patients, and now we have been using, in fact, yesterday we put a patient of drug-induced liver injury on the liver filter. So we have used it for drug intoxication and all. And what I want to show is, okay, so the number of sessions were 86% we gave 3 sessions, so that was the common number of sessions in our case, and outcomes. So there was an improvement in oxygenation in 50 patient data only. So I can't claim that this is something which is a huge data to really rely upon. So out of those 50 patients, 24 had improvement in oxygenation after the third session. And cytokine level, the IL-6 level after first session, 76% patient had reduction. Okay, the rest didn't have, and after third session, 90% of the patient had this reduction. Okay, so that was our data in COVID, and okay, yeah. So basically, start cytokine filtration when there is a severe organ injury and it is escalating. Don't go for IL-6 when it comes to sepsis. Recognize the indication early, use it aggressively for three back-to-back things, and use lactate and reduction in vasopressor requirement and reduction in organ injury as a most important sign for improvement after the hemoperfusion. Okay? If there are any questions, I would be very happy to discuss. Maybe now or after Sir's talk.
How do you anticoagulate?
So initially I had put those slides there, but then it was becoming too lengthy. 2 options. So he says, what is the situation with anticoagulation? There are 2 anticoagulation options which are available. One is the regional citrate anticoagulation, and other is the heparin. So you should understand why, interestingly, he is asking this is that the clogging of these cytokine filtration is more of an issue rather than the hemodialysis filter. So that's why the anticoagulation needs to be on a higher upscale side. So when we have a low flow system, that is CRRT, we go in for a regional citrate anticoagulation. But when we go in for a routine 3-4 hour session like that, and then we go for a routine heparin protocol. So unfractionated heparin, if we go in for a routine dialysis standalone or with a hemodialysis, but if it is a CRRT, then we go in for a regional citrate anticoagulation. Great question. So what he's saying is, does any antibiotic come in this range and the antibiotic get absorbed and you need to give a post-dialysis dose? So the data on Cytosorb is available, the data on HA330 for antibiotics is not available. So the doubt is regarding two antibiotics. Vancomycin is one, larger one, and linezolid is another. Still, it's not conclusive that they are absorbed to such an extent that we straight away given recommendation that they should be avoided or an extra dose to be given. But given that these two antibiotics are there in literature like that, if you are using vancomycin or linezolid in these patients, then I think we should prefer it to give post-cytokine filtration and not before. For rest of the antibiotics, so aminoglycosides, they are clear, cephalosporins, they are clear, carbapenems, they are clear. And vancolinid is an area. Polymyxins, nobody has tried.
Okay, it's the continuation, similar question. So are you saying that we have to combine the hemoperfusion and the CRRT together, or we can do the hemoperfusion alone?
And so if the kidney is an indication to do CRRT, please do CRRT. If the hemodynamics are fine, you only have to do cytokine filtration. Just do a 3 to 4 hour session of standalone cytokine filtration.
Yeah, regarding the vancomycin, actually, we can measure the level of vancomycin. It's not a good idea to just dose after just thinking that it might have got absorbed, because it is again nephrotoxic. So you can always measure the dose of vancomycin trough level. Then if it is less than 20, then you, in that case you can see, just don't give blindly.
Yeah.
So that is the thing.
So definitely, but unfortunately we are getting vanco levels, our turnaround time is 18 to 24 hours. So then, because vanco is something which is given for a crucial decisions and crucial infections, so that decision comes in our way. That's why we like to avoid vancomycin after going through this literature. So, but yes, vanco trough level is a good idea, and as she is saying that the recommendation now is to have a higher trough level compared to what initially they used to say, from 10 to 15, now they are saying 15 to 20, exactly. Any other question? Anything simple or basic? Yeah, sure. Sir.
Actually, we have a limitation in our country regarding doing when the patient requires the CRRT, because we don't have a CRRT. And we should go in this particular patient group. You have taken an example. If we have to start a RRT, the modality will be SLATE for us.
Yeah.
So when there is already when we are doing a SLATE, even the smaller molecules are not able to be cleared, and we try to do it for 6 to 8 hours in these patients. How you see the middle molecules clearance in these situations, and how it is going to be helpful, especially doing this hemoperfusion.
So sir, as I understand, he's saying that whether we should do SLATE standalone or not.
No,
So
I'm
he's
saying that SLATE, when you combine the SLATE, because this particular patient will require both the SLATE as well as whether the cytokine removal or not, right?
Sure.
So when we are removing with the SLATE the smaller molecules, right, and the cytokines, and we are not, because SLATE will not give the clearance as with the CRRT, right? So how you see that, because the damage that is going with the small molecule are not cleared enough, how it will be wise to combine both when we are doing SLATE with the hemoperfusion?
So as I understand your question, SLATE is not going to remove your cytokines.
Definitely.
So you are saying that you are doing a slow dialysis because of lack of availability of CRRT,
Right.
and the patient is hemodynamically unstable.
Right.
So the option is that you combine this SLATE with cytokine filtration. The problem in this particular combination is that you may like to extend this SLATE duration for 8 hours. And what I was discussing is that cytokine filtration should be limited to 3 to 4 hours only. So in that scenario, you need to increase the anticoagulation level. There is no recommendation that you should, in between the cycle, you shorten the sled or something like that. For the complete session of 6 to 8 hours, you continue, but please increase the level of anticoagulation.
So you have your experience on doing the slate with this
Yeah.
or CRRT only?
No. So we have experience on both the things.
Right.
So in our situation, not doing CRRT, yes. One issue which comes is the financial reason. The family may not be able to afford that. The second one is that the dedicated CRRT machine for our ICU is only one. So sometimes that machine is busy and we have to start another CRRT. So then the option left with us is only a SLED one. So we have used SLED conveniently for these patients.
Let's start with basic.
Comments to make.
Sure.
Sorry. I'm not with this. I'm intensivist. So, from what the information that you have just said, so I'd just like to make a few comments on the way we are trying to adapt this intervention into the ICUs. First of all, respectfully, I would like to differ from the recommendation that you have made at the end of the session, at the end of your slide, because the slides and the papers that you have presented are very selective, and you haven't presented the papers with a larger size, patient size, and better methodology. For example, one of the trials like Euphrates and other trials, which didn't show any significance in outcomes, either organ support free days or mortality. So there are lots of limitations. But I'm not against the potential use of like filtration techniques in ICU.
Yeah.
But from the limited data that you have presented, I would like to acknowledge that it's not good, strong enough to make the changes in our clinical practice. Like we are not at all in the position to adopt this intervention with the current evidence. But my next issue is like these companies, these studies, which are generally led by the industries, are spending so much in US and Europe, especially in Germany, where they have large registries and large clinical trials, and still the societies there do not recommend this as a routine intervention. Then why are we willing to try this intervention in our patient population outside the clinical trials? Why can't we lobby and apply or request the industries to support the industry-sponsored trials and use their resources so that we can come up with a better evidence? Because instead of just choosing the intervention based on case reports and like observations from retrospective studies, that is not going to help. Because there are examples in critical care where previous interventions, like so many expensive interventions, they do not work. We have to be very wise in choosing our interventions. So I'm just trying to emphasize on that we should agree on utilizing the resource in a better way, preferably within a research methodology, which should be sponsored by the industry. There's nothing wrong with that. And with that data, then only we can come to a conclusion that whether this is going to help or not. Thank you.
Okay, sure. So totally accepted, sir. But number one, I have only chosen those studies which have come up in the reputed journals, whether it is critical care or annals of intensive care medicine. Since the authors have not disclosed any connections with industry in these studies, so based on that lack of any evidence, I do not want to presume and blame the authors that they might have had connections with the companies and they would have tilted the study to their favor. That is one. Second, I think you are mentioning about Zwan et al. Is a large study which showed that there was no benefit in terms of mortality or in terms of reduction in vasopressors. But definitely there was a methodological issue in that particular study. But what I'm saying, what I'm trying to come to you is a broad picture. See, when our patient is worsening despite our adequate therapy, this is an option which is available for us. What my lecture was aimed at telling you what is the exact positioning where you have to think. There is no point of thinking of cytokine filtration when the end organ damage has happened. There is no point of thinking cytokine filtration when the patient is too early and he may respond to the standard sepsis management. So that is the positioning. So the idea is to tell you how to use cytokine filtration if you wish to use in patient. I said it in the beginning. Please use it for yourself and then decide whether it helps or not. Regarding industry sponsorship, yes, there have been studies right from Zygris and all, which were pushed by the industry. So if we get such an evidence that these particular studies were tilted, I don't think we should utilize those studies for our presentation. Very true.
Thank you. I'm Dr. Vijay and I'm from Prakti Medical College. I just have some basic questions like, first you mentioned about when there is, the blood is run through the circuit, then there is activation of complement labels. Why is it only complement labels for the activation of, for the inflammatory reactions? That's one. And the second thing is, you also mentioned about the incidence of hypotension, especially in young patients for the first time undergoing hemoperfusion, hemodialysis. They have hypotension, and that is mediated through endogenous catecholamines being surged. So as for my understanding, I think the catecholamines, they are a defense mechanism to increase the blood pressure. So is that a bit something paradoxical? Second.
Yeah.
And third thing, which I think Dr. Diktesh mentioned, I think there's also, I just have a small comment to put on that. I think there's a lot of tilting, a lot of bias in our field, especially when something new comes up. It's mostly pharmaceutical sponsored, and those studies definitely has to be taken with that pinch of salt. But yes, if you don't go for putting up such research, I think there's no way ahead. And another thing is also that in recent times, when so much of things about protocol and guidelines are coming out, especially in low-income countries like Nepal and India, I guess it's about that research into translational medicine, which has to be more focused. How much of our guidelines and our research are being actually used and being followed up in our critical care setup. And in fact, I have to say, although we are in a growth phase, but still the Nepalese Society of Critical Care Medicine, they are organizing this, so I think it's a big step towards.
Sir, in fact, I was extremely happy when I came to know that the society is planning a discussion on cytokine filtration. This itself shows that, see, we may reject it at the end when we have a data of say 2,000 patients or 1,000 patients like that. But till that time, if we are seeing an immediate response, there is no way for rejection also we will have to prove. So I am just saying that this is the position where we can try using this particular therapy, and also I am clearly saying what is my limited use in COVID as well as sepsis, and what is my plus as well as minus benefit. So I didn't claim that 100% of my patients they improved with cytokine filtration. So that is the thing.
My question.
Why
is
okay.
complement activation and why is that?
So as I understand this pathophysiology, that in response to a foreign molecule, complement is the first pathway which gets activated, and the complement activation is the first thing which happens when the blood cells are exposed to a foreign body. That's why I say.
Why is it that the tissue injury markers are more used for initiation of the growth process?
Acha. Okay. So when we were discussing the point when we should initiate, so I said one option is that you look at the level of cytokines. Okay. The other option is that you look at whether the vasopressors and those things are happening. The other thing is, see, we have to define that sepsis has reached to such an extent that it has created a havoc. So IL-6 is not the thing which will define havoc. If your tissue injury is increasing, that means there are enough cytokines that they are doing damage to the body. So that is the point which should be considered for initiation of cytokine filtration.
Thank you everyone, because of time constraint.
Sure.
We can continue questions
Yeah.
after the next session. So thank you so much, Dr. Ritesh, for an extensive presentation and good interactions. Without any further comments, I would like to thank Dr. Ritesh and invite Dr. Naveen Vasle for next presentation. Dr. Naveen is a nephrologist working at Sumelu Hospital who has extensive experience with patients with CKD. He is going to talk about role of hemoperfusion in CKD patients. Thank you.
So, hemoperfusion for chronic hemodialysis patients, what is our experience of it? So we have various modalities of blood purification for patients with renal impairment who cannot purify the blood from their own kidney. So among these, hemodialysis and peritoneal dialysis are the ones that we practice. The drawbacks are that these do not clear all the molecules like Dr. Ritesh said. Because we only deal with the small molecules and we have low phosphodialyzer, only clearing the low molecule. So we have a new modality, hemoperfusion, that was brought by this SMU and they wanted us to try this new modality. Theory part, Dr. Ritesh has already said, we are more worried about uric toxins than cytokines in chronic hemodialysis patients. And these molecules that we clear with hemodialysis, low cost dialysis, are small molecules. But those that are causing the complications are middle molecules and large molecules. So some of the popular middle molecules and protein-bound molecules are AZ and hemocysteine that are related to cardiovascular mortality, leptin that is linked to malnutrition in hemodialysis patients. Beta microglobulin, this also related to cardiovascular mortality, amyloidosis, and other complications of chronic hemodialysis patients. And parathyroid hormone, this also related to osteodystrophy, metabolic bone diseases, and cytokines like interleukin 1 and interleukin 6 that produce hemodialysis patients in chronic state of inflammations. So these patients are prone to, because of these molecules that are not removed, they are prone to complications like pruritus, low quality of life, high mortality, cardiovascular morbidities. And so this immunosuppression technique, what happens, like Dr. Ritesh said in his previous talk, blood is passed through the adjacent column, anticoagulated blood. They come in direct contact with the blood, and these molecules get bound to the adjacent column. So the one that was introduced is HA130. There are resin beads in the column and of the size 50 to 40 kilodalton. The one we talked in last session was 230, but one that we use in chronic hemodialysis patients are HA130 that are used for removal of uric toxins. So some data, we look for data if there is any evidence that whether it is a practice in other countries or not. And we came up for some data like leptin is removed, SSCRP is removed, parathyroid hormone is removed better than this conventional hemodialysis, low cost hemodialysis. So even some studies showed the mortality is improved in these patients who are receiving hemoperfusion. Sleep quality is improved, and even pruritus, the score of pruritus score is also improved with both HA130 and HA330. So still, like Dr. Ritesh said, there was no high quality research. Almost all the studies were from like China in small population, and we are not that convinced. So we look for if there is any other publication. So this was a recent published in 2021, a meta-analysis, and they had only found 12 good research on perfusion for hemodialysis patients. So the conclusion was that, yes, there was, hemoperfusion was able to remove this macromolecular toxins, and this inflammatory state was improved, the anemia was improved with less consumption of erythropoietin, and even cardiovascular condition stability was improved, left ventricular mass was improved. So quality of life also improved. The patients were able to sleep better. They had freedom from pruritus. So those were the kind of outcome the meta-analysis showed. So the manufacturer, the indications that the manufacturer had recommended in their catalog were, if the paraffin hormone was more, if the patient has hypothyroidism more than 300, or beta-nitrogen was more than 30, and there was complications that we face in clinical scenarios like pruritus, hypothyroidism, dialysis-related amyloidosis. Patients were resistant to multiple antihypertensive drugs, and the patient had sleep disturbances. So another indication was prophylaxis. If the patient opted for this modality, and only they wanted to avoid the complications. So this was also an indication they had recommended. And the contraindications were not much, not many. Only bleeding tendency and hypertension and this allergy to the hemoperfusion material. And the possible side effect that were written was again problem with coagulation and blood pressure. So we offered this to some of our patients that were selected clinically. Those were not improving with twice weekly dialysis and had gone to 12 hours of twice weekly, 4 hours of dialysis, and we selectively offered to some of our patients who we thought could afford, because one of the limiting factors of using hemoperfusion is the cost. So we handpicked some of the patients and talked to them if they would like to use this modality. So 6 patients we could recruit, and SBB Remedies offered them some subsidies that if the patients were happy and willingly agreed to participate. So the first patient was, like almost all patients were diabetic and hypertensive, and the hemodialysis, they had started from 5 months to somewhere, and dialysis for 16 years. But there were some complications that they were not improving with condensed hemodialysis of 12 hours a week. So the first patient, he was having problem with sleep. His blood pressure was not being improved. He has multiple joint pains, and he had recurrently pleural effusion. And the second patient, she was getting ready for transplantation, and she wanted for short duration, and she thought like a month or 2 months she would like to do hemoperfusion so that she is better ready for transplantation. The third patient, she was on dialysis with us for 7 years, and she was getting 12 hours of hemodialysis a week, but she had problem with sleep, again joint pain, severe joint pain. She had attended many orthopedic clinics, and the most troubling for her was pruritus. She had severe pruritus. She couldn't sleep good because of pruritus. She couldn't go anywhere with it because of the itch. So she was having trouble with these complications of chronic dialysis. The third patient, she was on dialysis for 16 years, and she was troubled that she had joint pain and she had restless leg, and which was not being improved with medicines or hemodialysis. The fifth patient, she had uncontrolled blood pressure. She was not eating well, so she said she would also want to try this hemoperfusion. So we did some initial blood tests for a few patients to see what was the biochemical markers of this. So most of the patients did not have significantly high IPTs or SSCRP, but beta-2 microglobulin was very high. So we offered them a package of 8 sessions of hemoperfusion over 6 to 8 weeks. And how we did was, they were already receiving 3 sessions of hemodialysis a week. So we offered them once a week. In one session, they would receive hemoperfusion along with hemodialysis in their hemodialysis session. With the this cartridge is connected in series without hemodialysis, low flux hemodialysis. So, and our anti-coagulation method was heparin, nothing else was changed. Blood flow was 200 to 250. So this is how we connected. This is the longer one is the low flux hemodialyzer, but the shorter one is the hemoperfusion cartridge, and those are connected in series with an adapter. Connected. So this is the first patient who was going to receive hemoperfusion, and he was anxious, so we put the first session in ICU so that he's more comfortable, and we are also more comfortable doing this in ICU for our first session. So this is like what was the outcome? What was the outcome of the patients? The first patient, he started sleeping better, eating better, joint pain was decreased, even the frequency of pleural effusion, the rise of pleural effusion was less. This patient was happy. The outcome, the patient gave us feedback that he was happy. But he couldn't continue more than 8 sessions, mainly because of the financial issue. So now we are waiting, like if we have already stopped hemoperfusion in this patient, will these conditions recur or not? Unlike what we discussed, cytokine removal, our hemodialysis patient have to receive lifelong of hemoperfusion for a good quality of life for the patients. So this is not a one-time hemoperfusion and stopping it, but they have to continue for the good benefit of it. So the second patient, there was no major complication when we did this. The patient was preparing for transplantation. So did it for 2 months. Unfortunately, she couldn't go for transplantation because there was some problem with the donor, and she chose to discontinue hemoperfusion. The third patient, she was very happy. She could find after only 3 or 4 sessions of hemoperfusion, joint pain had reduced a lot, and she was sleeping better, and she was saying that she was completely free of itching, pruritus. So she was very happy. She was so happy that she wanted to continue twice weekly hemoperfusion indefinitely. She said like she can afford, so she will do thrice weekly hemodialysis with 2 sessions of hemoperfusion a week. The third patient who already had a low blood pressure, and we were worried if she can tolerate hemoperfusion or not, because one of the complications stated was falling blood pressure. She was already having a borderline 90/60 blood pressure. We and worried about. We started her reaction was mixed. She was happy with the outcome, but again, every time we started hemoperfusion, her blood pressure fell further, and she had to be given fluids and stabilized before continuing the hemoperfusion. But she finished 8 sessions of hemoperfusion, and then she decided not to continue. The last patient that we had, the lady who we offered hemodialysis because of uncontrolled blood pressure. Our blood pressures was shooting even higher during the sessions of hemoperfusion. The main cause was that we could figure out was she was not taking her medicines regularly, because she was thinking that during the session blood pressure would fall, so she's not supposed to. We tried to convince her to continue, but after 3 sessions of hemoperfusion, she said she will not continue. So we couldn't get a good feedback from her, so she only did 3 sessions of hemoperfusion, but rest of the patients did 8 sessions of hemoperfusion, and most of the patients were happy. So that was the experience we had. So if you have any questions or comments.
So the circuit was veno-venous.
Veno-venous, yes.
Because I think in the diagram there was an arteriovenous circuit.
Oh, in the dialysis machine we say artery and vein, so that's what it was written. So unlike in CRT, we're using in conventional dialysis specialists.
So sir, what are the additional molecules which are removed?
Other than the urobic toxins, that we do not have data of. And I did not show the post data either. We did not get a good biochemical biomarker from this, because the beta microglobulin level was still high, more than 2,000 for 2 or 3 of the patients, and the patients are anxious, like you said. The level is still high, they said, but the clinical outcome was good. So we did not do other biochemical. Like in studies they have done it also for this cytokine removal one with what the same 130, but I think it's less effective than 330. And even for this cash nephropathy, they have used few case studies, not a very big good studies, and even for I think rhabdomyolysis they have used. But again, it's isolated some sporadic studies, case reports that we cannot rely on.
So you continue to recruit more patients? for
Yeah,
this?
I think more than us, I think these 6 patients, they are themselves convinced that it is better, and they are talking to other patients about like how good it is. And even our nurses, they could see the outcome. So instead of us going to the patients, they are now coming to us for hemoperfusion. We only talk to I think 3 or 4 patients first, then others are coming. Now, if those who are having some complications, the limiting factor is the cost.
Thank you for the presentation. New thing we have done. Theoretically, this should work because hemodialysis itself is a pro-inflammatory condition, and most of the outcomes are because of the inflammation. But the only thing is we should not be doing this in a we cannot generalize, because dialysis itself is an expensive modality of treatment, and especially in a country like Nepal, all over the world actually, it's a big burden to the health system. We should actually be selecting the patient who will benefit from hemoperfusion, like as you said, the people who have got peripheral neuropathy, who have got resistant pruritus and all. The other thing is we should have some biomarkers which we can rely and decide on which are the patients who will benefit from it. Then only it will be beneficial, rather than just depending on the clinical symptoms. But still, it can work for patients, because the pruritus, there are so many causes of pruritus, especially in our dialysis patient. Dryness is the most important cause. And carpal tunnel syndrome, that can, the peripheral neuropathy, and maybe the restless. But we should have a reliable biomarker, and we should have reproducible data on that, and then only we can say, okay, this hemoperfusion works. But maybe once a week for lifetime is going to be very expensive. We can do for a short period of time till the patient benefits from those symptoms. Yes, but I don't think it's economically very viable. We may have to find out, either we have to bring down the cost of this perfusion cartridge, or we may have to find another modality to remove the other middle and larger molecules, because people have tried with the high flux membrane, and there are problems with that also. So it's still a long way to go to have a nice outcome for the dialysis patients. Thank you.
Thank you for the comment, ma'am. Unfortunately, like I said, almost all data is from China, and we cannot copy the same in our setting. And there are no biomarkers that are reliable for this. We thought like beta-2 microglobulin will be reliable, but more than 2,000 before the hemoperfusion cases of hemoperfusion, more than 20,000 even after cases of hemoperfusion. But clinically, they show improvements. And this study, one of the studies, they say like these molecules will collect over 7 days. After it falls down after hemoperfusion, the baseline hemoglobin again come at over 7 days. So even in China, they are doing only once a week. So twice a week, if the patient can afford, there will be no harm. But it's really expensive. But cost analysis that China did, they say it's cheaper than diafiltration. That's one of the
For
modalities.
the monoclonal gammopathy, light chain disease, probably it would be beneficial.
But this, I said, 1 or 2 case reports. I think that's it.
If there are no more questions, I would like to thank Dr. Navi for this presentation and nice interaction. Thank you. So to make this happen, SPP Remedies and JAPFON have supported us, and from the eyes of distributors and importers of this cytozootherapy, I would like to ask representative of SPP Remedies to say a few words regarding this technology. So you would like to give vote of thanks.
So on behalf of SBP Remedies, I'd like to thank all the participants, especially Dr. Ritesh, Dr. Hem and Dr. Navi, and to make this program successful in a very short period of time. Actually, we had initiated this program very late, and within a period of a week, this program came into function, and we can see that the program has been successful. And I'd also like to thank the Critical Care Society along with the Society of Nephrology for being able to endorse our program. And we'd also like to have a similar kind of association in the coming future as well. Thank you so much.
So with this, I would like to thank Nepali Society of Critical Care Medicine and Nepal Society of Nephrology for jointly organizing and collaborating for this CME. And I would also like to thank all the participants for their active participation and for making this event successful. So to end the program, I would like to invite Professor Dr. Suraj Prasad Acharya to facilitate speakers, Dr. Ritesh and Dr. Navi, and the moderator, Dr. Hem, with token of appreciation. Thank you, everyone.